Welcome back to another session of Gratitude Week from the 1st to 7th July. We continue with a Thanksgiving marathon to thank our healthcare heroes for their untiring efforts and service to the nation during the hard times of a pandemic. And we will carry this gratitude in our hearts forever, not for a day, not for a week, but forever. And we want to thank doctors for going beyond their call of duty and serving the patients to the best of their ability. At the same time, they have also lined up a few awareness sessions during the Gratitude Week in a bid to empower people to take charge of their own health so that doctors can have better informed, more aware, and highly alert patients. This, we hope, will make the doctor's practice also more fulfilling. Now, in this awareness session, we are going to talk about the risk of stroke due to COVID-19 and how to care for patients during and after recovery. Now, this session is supported by URIHK Pharma, and we're very grateful to them for their support. Now, COVID-19 infection is known to cause acute respiratory distress syndrome and a hyperimmune response called the cytokine storm. Now, recent evidence is also showing that COVID-19 infection is an independent risk factor for stroke. This is because of the increased risk of blood clot formation in different parts of the body. The novel coronavirus usually attacks the lungs, causing symptoms such as coughing and difficulty in breathing. But doctors are now starting to worry about another important organ, that is the brain. Who is most at risk of a stroke after testing positive for COVID? What should patients and doctors be alert about? These are some of the issues that we want to discuss with senior doctors who are joining us now. So please welcome Dr. Darpan J, Thakre, consultant neurosurgeon, Krish Neuroclinic, Mumbai. And we have some of our doctors already with us, and we're waiting for the others to join in. Please welcome Dr. Raghavendra H, consultant neurosurgeon, SLG Hospitals, Hyderabad, Dr. Santosh Kumar, neurologist, KIMS Hospital, Bhubaneswar, Dr. Muthu Rathinam, neurosurgeon, Muthu Neuro Center, Dr. T.C.R Ramakrishnan, neurologist, KG Hospital, Coimbatore, and Dr. Rahul Gupta, Director, Neuro and Spine Surgery, Fortis Hospital, Noida. A warm welcome to our speakers who have already joined us, and we are very happy to have you with us. So let me start with you, Dr. Raghavendra. When it comes to stroke, most people think that stroke is just for old people. Young people are not going to be affected by this. But are COVID-19 patients more at risk for stroke? What have you seen in your practice?
Well, good afternoon, everybody. I just convey thanks to everybody for this opportunity. So to answer your question, ma'am, generally there is a lot of incidences of stroke I have seen in the last 1 to 2 months. It's not merely because of just COVID associated. We have seen in non-COVID patients with a lot of patients. And as we all know that there is one important thing as a surgeon, I have known the stroke is secondary to the this fungal infections, what I have seen more than this one. So fungal invasions and causing an angio invasion and that type of strokes are more common for me than classical strokes for me.
Sorry, Dr. Raghavendra, could you please elaborate a little on that? You said that what I understood, you've seen an increase in the number of stroke patients during the last year and a half, and that the incidences of stroke because of a fungal problem have increased. Is that what you say?
No, I mean to say that even the number of stroke incidences has increased in the last 1.5 years. And maybe just there is no much difference whether it is COVID as a cause of strokes or non-COVID as a cause. The strokes in young I've seen more in the recent past. And also the people presenting with secondary to this fungal infections, they also presenting as a strokes. We have seen large number, I mean to say that.
All right. Dr. Thakre, what have you seen in your practice? Have you also seen an increase in the number of stroke patients? Dr. Thakre, would request you to unmute yourself. You're on mute.
Yeah, thank you for the invite, and I thank URIHK for making, I think, this a great meet. So as a neurosurgeon, definitely we need to see both the neurological and the neurosurgical aspect of a patient presenting with stroke. And definitely during this COVID time, we have seen a definite increase in the number of patients with atypical symptoms. So it becomes really difficult for the neurologist or the physician to pick up that whether this patient is presenting with stroke or something else, because the thromboembolic mechanisms which are happening because of the vessel inflammation, they are affecting individual limb per se, wherein, one of my patients came with only right limb numbness and tingling. And when we got an angio done, it showed that the whole vessel was thrombosed. So something like that. So they are not following a classical pattern of stroke presentation, which we called as phase, where you have, or a past, what the neurologists say, that where you have a face involvement or an arm involvement or the gait is there, involvement is there. So yes, definitely active stroke, active COVID infection, and during post-COVID infection, usually it's late onset post-COVID, 3 weeks, 4 weeks down the line. That is what we are observing. And usually they are non-operable because the area of involvement is very small. So they get away with medications. And yes, diabetic patients and other comorbidities like patients on renal dialysis or hypertensive, they land up with major complications.
All right. Dr. Santosh is with us as well. Dr. Santosh, Dr. Raghavendra has said that he has seen more number of stroke patients coming in the last year and a half. Dr. Thakre is saying patients are presenting themselves with conditions which were not seen in normal stroke patients. What have you seen in your practice over the last year and a half?
Thank you, URIHK Pharma, for inviting me. Actually, in my hospital in Bhubaneswar, we have in our medical college, we have a dedicated COVID hospital too, having 1,000 bed and almost full since last 1 year. So whenever there is stroke with COVID, I used to get call, and since last 1 year, I have seen almost 100 patients COVID with stroke. And my observation is that during the second wave, without any risk factor and initially with 10 days of fever, most of the young patients presented with a large vessel stroke. It is not a very small stroke. Most of the MCA, ACA or posterior circulation completely damaged. So, which we had not seen in the first wave. And most of the patient having high mortality rate than the first wave where stroke presented. And second thing, these patients having hemorrhagic transformation, not only ischemic changes with hemorrhagic transformation, so that we have a very difficult situation whether to give heparin or not, because intensivist always giving heparin with steroids in all COVID patients. Whenever we are seeing the patients with a large MCA stroke and a hemorrhagic transformation. So we have a very difficult situation whether to give heparin or not, because if bleeding happens, then patient will die. So first thing is we are seeing more number of young patients. Second thing is large vessel stroke. Third thing is with high mortality. Fourth thing is with large hemorrhagic transformation. So tricky situation whether to give heparin or not. Means currently also 4-5 patients with these conditions are getting treated in our ICU.
Dr. Ramakrishnan, this is sounding very dire. First, you got more patients with stroke. Then you have patients coming with symptoms and conditions not usually seen in stroke patients. Dr. Santosh is saying, should we get them blood thinners or not, because they're having large vessels which are affected. What have you seen in your practice? This is sounding quite worrisome. Dr. Ramakrishnan, I request you to unmute yourself. You're on mute.
Okay. Am I audible now?
Yes, please go ahead.
Yeah. Okay. Thank you for the opportunity. Yes, as Dr. Santosh mentioned, actually during the first wave, there was a lot of hype that whether we had more strokes or more MIs. That was the discussion going on. At that time also we had strokes, which was more than usual what we usually see. But actually, at that time, we had the strokes were of mild strokes, and most of the people didn't have large vessel involvement, and most of them they did well. But the second wave is entirely different. Here, we have seen more patients coming with large vessel strokes. That means bigger infarcts. And the problem is some of them, for example, if they have got a COVID, most of them will be on anticoagulant. And if they come with hemorrhagic transformation, that means bleeding inside the brain, then it becomes really a problem for us. For the answer for your question will be yes, definitely we are seeing more strokes. The incidence is more. Not only the incidence is more, where these patients do not respond well to treatment as usual non-COVID patients. I have myself lost 4 or 5 patients with COVID and stroke. They don't respond. They keep on deteriorating. Ultimately, they pass away. This is our experience.
Okay, I want to ask this question to all of you, and you could please tell me your experience. Let me start with you, Dr. Thakre. Who is more prone to have stroke with COVID, after COVID?
After COVID, that is what is my experience.
No, who is more likely? I mean, if I have to be, if I have
young
comorbidities, young,
yes,
old,
yes,
who is more at
yes,
risk?
yes. See, number one is if the patient is already having comorbidities.
Like?
Number 2 is young patients. That is what we have seen. Even though they don't have comorbidities, I have found that the elder patients do better as compared to younger patients. And yes, other addictions, if the patient has, that adds to the problem and the outcome.
Okay. Dr. Ramachandran, the same question goes to you as well. Who is more at risk of getting a stroke with COVID or after COVID, in your experience?
You're asking me, there's
Yes,
nobody by
Dr.
name Ramachandran, I think
Sorry, Dr. Ramakrishnan.
Ramakrishnan.
So, yes, so who do you think is more prone?
With COVID or without COVID? That is your question,
so,
no?
with COVID and after COVID, who is more prone to getting stroke?
We are seeing more patients who come back after 2 weeks after COVID with stroke symptoms, especially people who have got comorbidities, like more in elderly people, like who have got diabetes, hypertension, coronary artery heart disease, all those people who have COVID symptoms, not pneumonia, either asymptomatic infection alone, or people who are there in the ICU for some time as a severely ill patient. They go home. Many of them come within a week or 1 to 2 weeks with stroke symptoms. These are the people, the COVID people who have got severe illness, who have got admitted in the ICU, treated, they come back with strokes. In these people, some of them, they come back with bleeding inside the brain. That's hemorrhagic strokes, either whether it is due to the disease per se or due to the anticoagulants which they have received. It's really tricky one to answer. But here the problem is the bleed. It is really a large bleed, and many of them we have lost these patients because of the huge bleed. Because of the huge bleed they had. So the answer would be we see more often stroke following 1 to 2 weeks following discharge in these patients, and hemorrhages is also common in these patients who have received anticoagulation and who are there in the ICU for some time.
Dr. Santosh, what has been your experience? Who do you think is more prone to having a stroke, either with COVID or after being treated for COVID?
I think with COVID, because if there is 2 things. After COVID means there is 2 situations. After COVID, if the patient is discharged from a hospital and if the hospital has monitored his or her D-dimer and inflammatory markers, he should prevent stroke by giving oral anticoagulants for 3 to 6 weeks. But if the patient, many patients are staying in home quarantine, so they are not coming to hospital and they are not doing serial checkup of their D-dimer. They having fever for 4, 5 days or 7 days, and suddenly they are developing stroke. So most of the patients during COVID, those who are staying in home quarantine also developing stroke. Means almost 5, 6 patients I have seen during second wave. They are means they are not hospitalized. They are staying at home quarantine, but they are developing stroke. So the difficult situation is that if they are not going and they are not checking their D-dimer serially, then it is very difficult to prevent stroke. So most of the patient in my experience and practice are those who are staying at home quarantine, and those who are moderate disease and saturation is also maintaining, but due to elevated D-dimer, they are developing hypercoagulable state and stroke. So both, and most of the cases are during COVID. Post-COVID, if he is discharged from a hospital, then most of the cases can be prevented by giving oral anticoagulants. But if they are at home quarantine, then it is difficult.
Right. Dr. Raghavendra, I would like to ask you, in your experience, who is more prone to get a stroke when being treated for COVID or after COVID? What category of people? Are they younger people? Are they older people with comorbidities? What have you seen in your experience? Dr. Raghavendra, you're muted. Would request you to please unmute yourself.
And for especially the last 2 months experience is not very tricky, madam. Generally, we used to see before in the first wave of COVID, those were the elderly people with diabetes and hypertension. They are more COVID prone. But this in the second wave during last 2 months, what my experience is, even young people are significantly affected during the acute COVID state, and whose D-dimers are very high, more than 10,000 like that. Especially these people are very much prone and they have suffered. As all my other panel people are saying, because we have high tendency, once you see the D-dimer level, we started giving with the low molecular weight, heparin, all those, or oral anticoagulants. Definitely there are high chances and they have turned out to be an hemorrhagic stroke. And sometimes this stroke in these people also, it is like a non-general classical areas where we can even do surgical interventions. Most of the I have seen is posterior circulation strokes, and they are not doing so well in the clinical part, especially those with D-dimers. Definitely in acute phase of stroke and high CT score when you correlate them, they have a bad prognosis. That's what I feel.
All right. We have Dr. Rahul Gupta also joining us now. Dr. Gupta, the senior doctors on our panel have so far said they have seen an increase in the number of stroke cases in the last 1.5 years. Patients are presenting themselves with non-typical, presentation of stroke. For COVID patients who have high D-dimer levels, they seem to be having a problem of stroke, and here the larger blood vessels are being affected. In your practice, Dr. Gupta, what have you seen? We're trying to understand who is more at risk for getting a stroke if they had COVID or if they are undergoing the infection now. Dr. Gupta, I request you to please turn on your camera and unmute yourself. I wanted to understand what have you seen in your practice over the last 1.5 years. Have you seen more stroke patients, and what kind of stroke patients have you seen? Who's more at risk? I think Dr. Gupta's connection is not steady with us, so I'll continue the discussion with the doctors if we have. Dr. Ramakrishnan, can you explain to me what is this D-dimer? For the longest time, we've heard that COVID will give you pneumonia. It will ruin your lungs. There could be a cytokine storm and any organ can be impacted. We have not heard so much about strokes or the risk of stroke because of COVID. So what is this D-dimer and how does it help you determine whether a person is at risk of getting stroke?
So the COVID is not only an infection per se. It is the immune response to the infection that is the reason for many of the complications we develop. Either the worsening of pneumonia or the complication which we get is mostly due to the immune response. So the COVID, it also has got a coagulopathy effect. That is, it has a tendency to cause coagulation problems both in the arterial side and also in the venous side. To estimate, to have an idea of this effect is what the test done is the D-dimer test. The D-dimer test helps us to assess the patient's risk for developing these clotting problems. So if they have got a high D-dimer level, they are likely to develop clotting disorders, because one of the theories for even for the pulmonary problem is because of this clotting which occurs in the small vessels in the lung, which interferes with the air exchange, and because of that they develop pneumonia. So to assess this only, the D-dimer is being done. If the D-dimer is high, then we start them on anticoagulation. The idea of giving anticoagulation to prevent clotting from occurring either in the lungs, either in the small vessels in the leg, or in the heart, or in the brain also. But the problem is, some of them, it is like a protective mechanism going unabated. So if it exceeds the limits, these things becomes counterproductive and results in tough to us. Either it results in stroke or acute coronary syndrome or a cortical vein thrombosis like that.
Okay. Dr. Thakre, could you please explain that point more? Anticoagulants are being given to COVID patients so that the clotting doesn't happen, so that their heart doesn't get affected by the clotting or the lungs don't get affected by the clotting. But because of these coagulants, you're getting a stroke. I mean, is this right? Have I understood it right?
See,
no, it is not like that.
No, it's not like that. We have two types of strokes actually. One is a hemorrhagic stroke and another is a non-hemorrhagic stroke. So in non-hemorrhagic stroke, you have a clot within the vessel. So the periphery to that vessel, the blood is not reaching and you get a dry infarct. And second is a hemorrhagic stroke wherein the vessel ruptures either because of raised intracranial pressure or you have thinned out the blood to such an extent that it is like more than twice or thrice than what it should be. So we have some regulatory markers to check whenever we are giving blood thinners, to what extent are we expecting the blood to thin out so that the patient doesn't land up with pulmonary embolism or a cardiac embolism or a stroke in the brain. So that is called as PT-INR. So we check the prothrombin time, the INR values, and we titer the blood thinners which are given to achieve the maximum response in these COVID patients. And most of them, they go on ventilator or, they're not mobile in the bed. So you'll end up with deep vein thrombosis in the legs. So all those things need to be taken care and the dose has to be adjusted as per the requirement of the patient depending on the age of the patient and the comorbidity.
Okay. So what is the, why is there a presentation of Dr. Thakre, patients with a large vessel involvement? What is the connection with having taken anticoagulants and, the large vessels being impacted? Because you said vein thrombosis in the leg would be smaller veins, right?
Yes.
So one of the panelists said that large vessels were impacted. So where is this? How is this happening?
The thing is, we are confusing here with the arterial part and the venous part.
Yes.
So legs, when we talk about deep vein thrombosis, these are the impure vessels which are carrying impure blood from the legs towards the heart. When we are talking about the large vessels, they are the arteries basically. So it all depends on the susceptibility of this vessel wall to this infection and the inflammatory response which happens because of this infection. So it is a retrospective study. It's not that, because it's a learning curve for everyone right now with the COVID coming into picture. So this is a retrospective finding what most of the neurologists or physicians or the intervention guy have found out, that large vessels in the brain basically are getting affected and they are finding major areas of strokes or infarcts or bleeds. But I feel in India, there might be territorial distribution of these findings, maybe because I'm in Maharashtra and maybe the other colleagues are more towards south. So the lifestyle, the pattern of presentation might vary. It is just what I am thinking, listening to my other colleagues.
All right. Dr. Raghavendra, could you also dwell on this? I want to understand, is there a difference between geographies on the kind of stroke patients you're seeing? Plus, are you seeing stroke patients coming to you in time? Maybe they have COVID, they've recovered from COVID, but are they coming to you in the golden hour? Because as much as I understand, patients who arrive in the golden hour have a very good chance of full recovery. What are you seeing?
Generally, those people who are from the periphery area, definitely they come, whether it is COVID or not COVID, generally they don't come in the golden hours. Okay, the J is to come very late to the clinical, this 1 year department. So by the time what a neurologist is to consider for thrombolysis or a mechanical thrombectomy, the time is generally lost for those people, whether it is COVID or not COVID, I feel so. And maybe the COVID has made still that in a very worse state because of a lot of
restrictions,
border issues, all those things. I accept that. But people who are coming in a little early, definitely they are a little better compared to those who miss the golden hour chance.
All right. Now, I'd request all our speakers to please turn their cameras on so that we can see them, and then I can go to them for the next question as well. Dr. Ramakrishnan, what is your experience? Are patients coming in time? Are patients aware on how to keep a track of their conditions? Are they getting D-dimers done? Because, honestly, in the second wave, to even get a telephone consultation with a pulmonologist was an uphill task. They were not available. They were so pressed. So we would go to the family doctors and they would say, monitor your oxygen, monitor your temperature, take paracetamol. And that is what we did. Maximum, we got a CT scan done. Now, the advanced tests or D-dimers, etc., are these only for those who were admitted into hospital, who got steroids and other treatments? How can we proactively, get this message across that people can be proactive about their health? They can, keep a watch out for symptoms. What is your experience been like, Dr. Ramakrishnan?
So first thing is whether the patients are coming to the hospital on time.
Yes.
Even before the pandemic, the general percentage of people who come to the hospital with acute stroke within the time window would be around 20 to 30% only. 70% of the time they don't reach the hospital, especially in semi-urban areas, to the hospital. After COVID, this number has even come down. See, we would have generally, if we have thrombolized 20 to 25 patients in a year, in the last 1.5 years, it will be half of that only. So the number of people coming to the hospital with acute stroke has definitely come down. Second, probably even during the first wave, there is a lot of confusion among the team itself, because even if they come to within the time window doing COVID test, triaging the patient, and imaging, it took a lot of time. So some of them we couldn't thrombolize because of those issues. But in the second wave, we have learned and we have sorted out these issues, and triaging hasn't affected our ability to thrombolize these patients. So one thing is that definitely the patients have come down. The people who come to the hospital within the time window have come down. One, because of travel restriction. The second one is people are really worried or fear. They have, if a hospital has got good COVID and non-COVID treating patients, people are really worried to come to the hospital, especially because of the fear of contracting the virus in the hospital itself. That is one thing which made many of our patients to stay back and call us. D-dimer test, as Dr. Santosh was telling, generally, that's my understanding, for people who doesn't have any lung involvement, and if they're at home, they don't have symptoms, probably we haven't asked them to do D-dimer. But if somebody has been in the hospital, has received the treatment and gone home, for them we have monitored the D-dimer levels both at the time of discharge and after they come, ask them to come for review after a week and do the D-dimer test, and we have done that. And we have manage their anticoagulation based on the results of not only of D-dimer, we do ferritin level, we do LDH also, and based on this test, we just adjust their treatment accordingly.
Right. Dr. Raghavendra, would you like to add something here?
No, I just see one important thing is sometimes I feel these online consultations are misleading things. Maybe what the people have been complaining. Recently I experienced one patient, a young female, being just told headache, has been treated as because of the fear factor of coming out or all this COVID. And if she was being just treated for it turned out to be a big thrombosis once she came in altered sensorial. See, this is one of the lessons to be learned, just not merely on the clinical symptoms. At least we just don't miss certain important things. That's what I wanted to add to this point.
So, Dr. Raghavendra, could you explain what happened here? The lady had a headache.
See, the patient was on an online consultations for somebody. Okay, she has been treated for a headache only. So just people are giving an online consultation for an NSAIDs. Generally, we give naproxen or something like that. So the headache was not coming down. Suddenly, she comes to an altered sensorium state to us. So that when we diagnosed her, she doesn't have any COVID, but maybe because of the COVID pandemic, the fear of coming out into the hospitals, she finally landed up in an altered sensorium because of there was a CSVT.
Sorry, Dr. Raghavendra, some of the terms you've used are pure medical and we've not understood.
Okay,
what state did she present herself with? What was her diagnosis and what was her recovery? Could you explain that to us?
She was in a semi-comatose state, I can say. Means I just wanted to say here is an administrative or what do you call that? Because of online consultation, the diagnosis could not be clear. It was not made proper. So we miss the diagnosis, which can be treated very early with all those anticoagulants. Because of the misdiagnosis, she has to suffer a little more. That was one of the sad part of the last treatment.
But did she recover?
She's doing good, but she has to go through a lot of hurdles, which can be prevented if we had been intervened at the early stage.
Right. Dr. Santosh, I was asking our panelists to talk to us about this D-dimer and who should be doing this because, a lot of COVID patients are recovering at home. And unfortunately for us, many people have taken steroids on their own, other medicines also on their own without consulting their doctors. Now are they at risk of, perhaps a stroke? Who all should be monitoring D-dimers? Should all COVID recovered patients be monitoring this? How can one reduce the chance of a stroke?
No, I will not suggest that all COVID patients should monitor D-dimer level. The guideline is that if it is moderate to severe, then you should monitor the D-dimer, and it is not the one test. If you have done on day 3 or day 4 of fever and it is normal, then better to recheck at 2 days, day 7 or day 10. So that serially monitoring is the best. Then similar thing during recovery or after COVID. If hospital at the time of discharge, if it is high, then you have to monitor what time the level is coming down. And up to that week, you have to continue anticoagulant. I will just add in the previous question during that is thrombolysis during COVID and stroke. So what difficulty we faced? First, as already discussed, the transportation issue. Second thing, in my hospital, we faced that one is logistics, second one is the manpower. Because in COVID hospital, most of them are interns and first year PG students. So they are not able to diagnose stroke at the early stage because many patients develop stroke in hospital. During admission in COVID hospital, they develop stroke. But they could not diagnose during the window period. If they will not diagnose, because we as a super specialty, we are running our OPD, our IPD, all these things. So we are not posted in our COVID hospital. So they are posted, they will call us, and they are not timely calling us because they are not able to diagnose. Second thing, proper timely CT scan, because whatever CT scan is there, it is in the non-COVID side. So we have facility of CT scan at a proper time, like a time slot in evening 7 to 9, all the COVID patient will underwent CT scan. So later only we meant put 2 CT scan, which is dedicated for a COVID side and one is non-COVID side. So if, for example, if morning one patient developed hemiplegia, so he has to wait up to evening 5 to underwent a CT because his slot will be opened at evening. Because throughout daytime, all the non-COVID CT will be going on. And third, that time, so much delay happened, and so we could not thrombolize the patient. So these are the difficulty for stroke thrombolysis. Though these patients are admitted in hospital, developed stroke in hospital, but we could not thrombolize many because due to all the manpower logistic issue.
These are also very important concerns. I would again request Dr. Rahul Gupta and Dr. Kumar Sahib to please start your cameras so that we know you're here and we'll come to you. Dr. Ramakrishnan, are logistical issues and manpower issues also serious concerns? And how many young patients have you seen who developed a stroke because of COVID or in recovering from COVID?
Probably I may not have seen that much patients as Dr. Santosh is mentioning, but a handful of one, probably less than 10 young patients who have COVID and recovered from COVID or during the COVID had strokes in this second wave. But unfortunately, many of them had large infarcts and some of them had bleeds also. The people who has developed, especially young people who has developed strokes, they didn't fare well and we have lost quite few of them. Ours is it's a corporate hospital, so the logistic issue was there, especially during the first wave, because when patient with COVID or at that time we don't know when the patient comes whether he is having COVID or not COVID with symptoms. First we have to test the PCR, then only the further things was happening during the first wave. But during the second wave we are little organized, so we had a less. Dr. Santosh was mentioning, we have put a separate CT. So once the patient comes to the hospital with symptoms, we did the CT brain, we could do the CT chest and have an idea of COVID. And we have added the facility of doing thrombolysis even in the ER itself. So in that way, we are able to do thrombolysis during the second wave. But during the first wave, we had a lot of logistic issues. But personal problem was not there because this was a corporate hospital and it's a private concern. So that was not there. And our patient load is not like thousands. It was during the second wave, maximum we had around 350 to 400 patients with COVID at that particular time. But non-COVID patients were less during that time. So these issues were not of much concern. But young patients, yes, we had. But unfortunately, young patients who had strokes didn't fare well when compared to older people.
What could be the reason for this, Dr. Ramakrishnan?
Yes, because most of the young patients had large vessel involvement. See, you are discussing, no? See, large veins, smaller vein. That is not the issue. Large vessel means the vessel which carries blood from the heart to the brain. There are internal carotid arteries, and vertebral and basilar arteries. These are called as large vessels. So if you have developed a stroke, an occlusion in the internal carotid artery or in the middle cerebral artery, one half of the brain, nearly 40% of one half of the brain would have been affected. So these are really large ones. And especially if it occurs in young people, sometimes we have to do surgeries for decompression and all. And especially in the in between time where he had oxygen issues and all, to take up a surgery is a Herculean task. So during those times, this is the main reason, especially bigger infarcts, younger people, and those who developed hemorrhage also. The hemorrhage, we thought we're not really sure. It could be due to the anticoagulation we are using, or it could be due to the disease process also, because disease is not as simple as what we think of. Because even for mucormycosis, our surgeon who does surgery, he says he's seeing a lot of clotting inside the nasal mucosa. It is due to the clot plus infection per se. So it is not like the simple clot. So because of these issues, we have lost the patients, especially younger ones.
Dr. Santosh, yours is a very large facility, but usually what is understood is it's best to take a patient to a stroke-ready hospital. So what happens, in a pandemic, all facilities are overwhelmed. Are most health facilities now stroke ready, having seen that the risk of stroke is going up after COVID? So are most hospitals stroke ready?
No, we are a stroke ready hospital. We have neurologist, neurosurgeon, intervention neurologist, everything. But we have manpower issues, because I am telling my hospital built 4 peripheral COVID hospital due to government pressure. So we have one medical college and attached to COVID hospital, and throughout Odisha we have 4 peripheral COVID hospital, which is managed by our staff only. So all our surgeons and intervention specialists, medicine people, and few neurologists are posted to outside. So we have a severe manpower issue, so that we could not run our stroke protocol during COVID time, and specifically during the second wave. Second thing is the fear, because if you go take the patient to a cath lab, so fear of contraction of COVID by intervention radiologist, he has to do the thrombectomy, then anesthetics people. So lots of fears are there. So that's why means in second wave, when many patients we lost, most of the patients are young and large vessel stroke, and only 2-3 we could thrombolyzed, and that also don't have a much improvement after thrombolysis, having significant disability, because whenever we did the CT, it was normal and with thrombolysis, but they have not much improvement. I don't know why they have not improved, unlike the non-COVID patients. But COVID patient stroke after thrombolysis, it's not much improvement after thrombolysis.
Is this what you have also seen, Dr. Thakre? That after thrombolysis, also younger COVID patients have not seen the same recovery as non-COVID patients? Dr. Thakre, you're on mute.
Yeah. So, I'm attached at PD Hinduja Hospital, which is at Thar. So definitely we don't have that great numbers as other colleagues are having. But whatsoever patients we have got as a team of neurophysician, neurointervention, neurosurgeon, we were able to salvage a lot of patients. And yes, those who had comorbidities, they had finally succumbed because of the comorbidities, but not per se to the brain reason why they came for, like stroke. So there were cases wherein we did a decompressive craniotomy. The intervention guy went in and did and removed the clot. So we had relatively good results. Say out of 10, at least 7 had survived.
Mm-hmm. All right. Dr. Ramakrishnan, what was your experience? If you gave thrombolysis, how did the COVID patients respond as opposed to non-COVID patients? What was your experience?
If you are able to thrombolyze the patients, they have done well. But even what shall I say, for the numbers, for example, if before this pandemic, if the percentage, if you see, no, so for example, if you're going to thrombolyze within 1.5 hours, 60% of them will do well when with thrombolysis. But that numbers are not there. They improve to a certain extent, but not to the level which we expect before this pandemic. But even without thrombolysis, as Dr. Thakre was mentioning, patients who come, for example, after 6 hours or 8 hours and who have got COVID, whom we give as usual, whatever we do for the non-COVID situation, these patients generally, over a period of time, they decline. Slowly, they deteriorate and ultimately succumb because of either due to the comorbidities or due to the respiratory complication they develop. This is what we have seen. But people who have thrombolyzed have improved, but not to the expected level which we have seen before.
All right. Now, I want to talk about how can people be aware of the symptoms, because you have told us your experiences, and what we've understood is that stroke is a very important risk for COVID, and many people are not faring well after getting a stroke, either during treatment of COVID or after COVID. So for a normal lay person, the test is, I think, the one-arm test. And so could you please explain what are the symptoms that people should be aware of so that they know that something is wrong? It could be a stroke. I need to rush to a stroke-ready hospital. I'll go with you, Dr. Raghavendra. Could you please explain in simple terms what should people be watchful for, especially if they've had COVID or they already have an COVID infection now? Dr. Raghavendra, you're muted. Could you please unmute yourself?
Hello?
Yes, please go ahead.
Ma'am, whatever is there has been taught from our school days that be fast to treat fast. So we tell the people to address these 4 symptoms like any finger weakness or in arm difficulties or speech disturbances, and address the people. Any change in the neurological thing, we have to address the people very fast, inform the people so that they can reach early. And like some other symptoms like uncontrollable headache or uncontrollable giddiness, so even sometimes altered sensorium, then sometimes it's like a fits, all these things has to be made alarming to the people so that they reach the hospital, to the stroke centers very early.
But Dr. Thakre, Dr. Raghavendra himself gave an example of this lady who had a headache and she was teleconsulting, and people thought, oh, it's a headache, it's COVID. No, COVID mein to headache hota hai. And because of this, she didn't get the diagnosis and the treatment early on. So how do we know that this is not a regular headache, that my symptoms could be COVID, since nobody knows this is a new disease? When do you know that something is really wrong? You may have COVID, but something is really, really wrong and you have to go to the hospital. What are the things to watch out for?
I think there is a list of constitutional symptoms besides the headache, which the patients usually they miss it because they are so very used to taking medicines over the counter. It
Mm.
might be a simple cold, common cold, so they are not able to differentiate between a normal viral fever and a COVID viral infection. So most of them they first go to their general practitioner who will try to do something, give some combination of 3 4 drugs into one pill, which usually has steroid, which makes them feel all right for a couple of days. And once the drug effect goes off, and then they have a flared reaction, and then they present. So yes, it is difficult to guide common man, but we need to make them aware that now in today's time, the malaria and dengue coming into picture, we are seeing more of those patients also overlapping with the COVID symptoms. So it's become like for the clinician to be more dependent on the clinical symptoms than the blood reports. So to go more in detail with the history, not of 1 or 2 days, maybe 15 days back, because the patient is young, he might get away with the milder symptoms because of his immunity. But if the immunity is down because of XYZ reason, then he might land up with severe symptoms. So awareness definitely is required,
So,
and I
Dr.
think
Thakre, what would you say is the symptoms that people should be watchful for, that this is more than just COVID? It could be a stroke. What should they be most watchful about? Like a headache is one which Dr. Raghavendran said that an unusual headache should alert you that this is something more. What are the other symptoms that one should watch out for if you already have COVID?
yeah. Now, if it is pertaining to only brain and spine, besides the headache, which is responding, not responding to medications, there might be subtle weakness on the face, some deviation of the angle of mouth, some ptosis or drooping of the eyeball or the eyelid, tingling numbness in the hand or leg. It might be one limb or any side of the body, which they can appreciate. Mild low-grade fever associated with all these complaints. There might be subtle imbalance in the walking. The patient starts swaying towards one side, and there is incoordination of movements. If he's trying to catch the glass, the hand is swaying towards other side, or he has tremors. So maybe these are few red flags which I will tell my patient to watch for.
Okay, all right. Dr. Santosh, is there anything people recovering from COVID can do to secure themselves from the risk of getting a stroke?
The first thing is that, as already discussed, if they having moderate and severe disease, then they have to recheck and or serially check their D-dimer level. First thing. Second thing is early resumption of physical activity. If they are prolonged bedridden or they are not doing any physical activity after recovering of stroke, then it is very difficult. I am telling, in Bhubaneswar, we have a cycling group of around 10 neurologists with psychiatrists, and 2 neurologists were affected with COVID and they recovered. And after 5 days, they are now doing 60-kilometer cycling. So Sunday we covered 70-kilometer cycling. So early resumption of physical activity is very important. You by doing only activity, you can beat all these things. Second thing, as I already told, serial checkup of D-dimer if they are very sick or moderate to severely sick. So we can prevent that. It is not very difficult because many people are not doing serial checkup of their D-dimer level, because it is not only in hospital, they can do in private lab also. If it is high, they can consult and easily they can take medicine. In that way only we can prevent.
Dr. Santosh, what about those who've had mild disease?
Mild disease, I don't think they will develop stroke. It is very, very rare if they having mild disease, if CT severity score is less. Because the issue is that mild means who is telling them that they having suffering from mild disease. They should not consider themselves as they having mild disease. The doctor should tell that okay, the inflammatory markers are not rising, CT severity scores are not high. fever is not constantly coming, after 3-4 days by simple paracetamol fever subsiding, then they will not develop stroke. And if it is already 10 days over, then it is very difficult that there is further deterioration if not happened in the first initial 10 days. So means somebody means some doctor should tell them that okay, you don't have any severe or moderate disease.
Okay, Dr. Ramakrishnan, I want to understand from you what should be the important symptoms to watch out for, and how can people protect themselves? Because Dr. Santosh is of the view that those with moderate to severe disease are more at risk of getting a stroke. I know many people who have had COVID, have stayed at home, have taken the medicines, consulted their family doctor or a friend, and never got the D-dimer, never got the CT scan, they recovered. So should these people not be worried at all, or should they also then check with their doctor, get a CT score done, get a D-dimer test done to just prevent the risk of a stroke? What's your opinion?
First thing, what we have done is to improve the ability of the people to detect stroke. We had a pamphlet which contains a mnemonic Be Fast. That is BEFAST. So we put this into all the people who got admitted at the time of discharge. We gave them along with their discharge summary. This is B stands for balance. That means any acute onset of balance problems. If they, whatever Dr. Thakre has told in a little familiar manner. B stands for balance problems. If they develop acute onset of balance disturbances, 1B. E means any eye disturbances. If they have any double vision, if they are not able to see clearly. F stands for face. Any facial deviation if they develop. A stands for arm. If they develop any arm weakness. S stands for speech disturbances. So we put a pamphlet containing these letters, and T stands for time. So if they develop these symptoms, they have to come to the hospital immediately. This B Fast mnemonic, we made a pamphlet and kept it on all the case sheets and we gave it to the patients at the time of discharge so that they can understand these things. Second one is, see, for example, these strokes or whatever we are speaking, the complications due to the coagulation problem only. And this doesn't occur with people who just has got an infection, just COVID infection without the disease per se. So, for example, many people will have fever, body pain for first 4 days, and they get better by the 5th day or 6th day. These people just had an infection, they haven't gone to develop disease. After 5 days, if they again develop fever, if they develop body pain, or if they develop a cough, brassy cough, these are the people who had developed pneumonia. So these are the people whom we have to do a CT test and score them, and probably we can take the treatment according to the CT findings. So these patients who had just had fever, body pain for the first 4 days, and after them there is no symptoms at all, they can be kept at home. And I haven't seen, for example, I myself a doctor, I might have treated so many of my friends, and none of them has gone to these complications. The patients who have developed these complications are the one who, after that initial viremia period, during this immune phase, who have developed these symptoms like the recurrence of fever, occurrence of cough, and had CT findings, are the one who has developed stroke. So we need to follow these patients who there was a need for CT or who have undergone CT. It is not that we need to do CT for all people who have contracted COVID. It's not like that. Only for those people who develop recurrence of cough or who have developed recurrence of fever after 5th day of illness, they get better and they again come back. Those are the people whom we have to do CT. And people are comorbidities, age more than 60, has got diabetes, has got coronary heart disease, has got systemic hypertension, or who are on any organ transplant or an immunosuppressive therapy or a cancer patient. These are the ones whom we have to do CT and monitor them.
All right. So we've got quite a comprehensive list of red flags, early symptoms to keep a watch out for, and who is more at risk. Thank you all for joining us today.